So let's welcome Dr. Cisneros back for a second time. Thank you, Dr. Cisneros.
Thank you. Thank you, Nancy. Good morning. I'm Dr. Cisneros. I'm the medical director of Hospice Inspiris here in San Antonio. I've been a medical director of hospice for the last 12 years and have been making house calls, visiting patients and families at their home, many times a personal care home, nursing centers, and hospitals as patients experience the last few days, weeks, or months of their life. As we were saying last week, we say that good health is just the slowest rate at which we have the decline. And when we go into the final phase of our lives, the end of life, we begin to notice that our patient or our family member begins to withdraw. And the most common thing that we begin to experience is that their physical activity really declines, and they begin to sleep more, and they begin to eat less, and they get less involved in their activities of daily living and their socialization. So how do we know someone is dying, and how do we diagnose the death and dying is something that is really difficult to predict. And we as doctors, studies show, are only about 38% accurate when it comes to prognosticating. We're very good at diagnosing and treating, but we're not so good at the prognosis aspect of end-of-life care. And there's really no marker in the blood work. There's really no way that we can see any particular sign or symptom except for this constellation that I mentioned, that a person will become more frail, will not be eating, and begins to withdraw. Patients need to be considered for hospice or end-of-life care, and as a rule, most patients get referred very late during their last stage of life. And it really does the patient and the family a disservice, because there's really a shift of focus that we need to have in the culture of death that we have here in the United States. We need to shift that focus to going back to the home setting, wherever home may be for that patient or loved one. And as I said last week, it is a grassroots effort that started back in the 60s, and then in 1982, the Medicare benefit began to cover the hospice benefit. And we do see now more and more people accessing hospice, and probably 1 out of 4 Americans who die access hospice care. And when they do access hospice care, they can see what a great service it is, because they get a team of professionals to come and see them at the home, and really also focus the care on the goal and expectation of the patient. And that's one of the other things that we do see in this evolution of patient care here in the United States, that it becomes very important to have, we say, the autonomy of the patient, the self-will of the patient. What does he or she want at the end of their life? And we make decisions, we make choices, but when it comes to end-of-life care, it's one of those things that people really freeze up over, and they have a real difficult time discussing. But we do need to bring it out more in the open so that people understand their choices and get this education for end-of-life care. The topic today is going to focus on pain management at the end of life. And pain management is really the cornerstone of what we do in hospice care. We have so many people that die here in the United States that die in severe pain. And it's something that we can really minimize, because we do have that expertise with hospice services. It's a tragedy to see someone that has not had any pain management, that they have an illness, in particular, let's say a patient with cancer that has severe metastases in their bones or their organs, and they have a very difficult time with pain. And the treatment focus is usually on curative approach, but if we don't adopt a palliative approach, which is, as we said last week, palliative care is focusing really on the symptom of pain, or trouble breathing or nausea, whatever the symptom may be, and focusing on the emotional and the spiritual needs of those patients, the patient will suffer. So we do a very good job of really looking at this symptom assessment scale in each individual patient, and then seeing each individual patient's goals and expectations, because those symptoms are the symptoms that really make a difference and impact the quality of life, they impact the quality of life that's remaining. So if we can address that symptom and minimize that symptom, then the quality of life will be improved. And probably one of the biggest fears when we do face the end is pain. And when we have pain, it's by definition, we say pain is whatever the patient says it is, whatever discomfort or distress it is. People don't want to be considered complainers, and it's real difficult to get them to report pain. But we need to report pain just like we report blood pressure or blood sugar. We need to ask patients what is their self-report, and get away from the habit of asking, are you complaining of pain? Because people will always want to be very stoic, many times hold back and not report that pain. So number one, we need to ask them on a scale level between 1 and 10 what their pain level is. And we say the level 1, 2, and 3 is mild, 4, 5, and 6 is moderate pain, and 7, 8, 9, and 10 is severe pain. And then the level of pain will help us know specifically what medicine we can use to help their pain. And there's a lot of advances, and there's really wonderful medicines, routes of administration that vary, that we can really get most patients under good control of their pain. When people have pain, we also can divide it into acute pain or chronic pain. Acute pain is anything that lasts several days after an injury, up to maybe a few weeks. But when pain is longer than 6 months, we consider that chronic pain. And one of the biggest mistakes that I see in pain management today is that we don't put people on long-acting opioids or pain medicines to give them the around-the-clock pain relief that they need. And it therefore breeds sort of we call it a pseudo-addiction or a false addiction, because they're asking for pain every 4 hours, and we're under-treating their pain. And there is a difference between addiction in the realm outside of hospice, because when patients come on hospice, we have a very short time to live, and addiction should not be an issue. And studies show actually that it's probably less than 1% of patients that come on hospice that have problems with addiction of their pain medicines. And it's one of those big barriers that we always have to try to cross, and we have to feel comfortable as physicians and nurses and caregivers to be able to make the patient comfortable to take the pain medicine and not let them suffer needlessly. And it's a huge issue. I think morphine, and we call it opiophobia, being phobic or fearful of opioids is one of the biggest barriers to effective pain management. In the past, the fear was great for addiction, and for really it was underutilized, and then it swung the other way. And I think there are a lot of cases where people are addicted to opioids today. But when we look at the hospice field, the end-of-life field, addiction should not be an issue. We need to really relax about that and not really get uptight, because when we do, the patient suffers. And we do need to be more liberal, because they do have conditions that are very painful. And we classify pain, as I said, into acute and chronic pain. Most of the patients that come on hospice do have chronic pain. And then we also classify pain as somatic, or your body, your muscles, your bones, your joints. That's called somatic pain. And then we classify it into visceral pain, the viscera or the internal organs. And we can start with the brain, the lungs, the heart, the liver, the pancreas, and then you move on down the intestines, the pelvic area. Those are the visceral organs that can give you pain. And then you have the nerve pain, starting with the brain and the nerve endings that come from the brain, the spinal cord, and the nerve endings. Of those three types of pain, the somatic pain is probably the easiest to treat, followed by the visceral pain, and the nerve pain is the hardest to treat. And the other important concept with pain management is that you have to think about the total pain of the patient. And by total pain, you're adding up not only the body, but you're also adding the emotional and the spiritual realm of possibilities. So when I visit a patient, and I had a patient one time that had a pain level that he said was a 20. But when we did more interviewing, it turned out that he had been estranged from his family. He was a military officer who was living alone, and he had a tremendous amount of loneliness, and he was facing the end of life without having his family call. And when we began our team approach of helping him, we didn't have to put him on morphine. What he needed was emotional help, and having people surround him so he wouldn't feel so lonely. And I think this is really important with hospice. People form these relationships that are wonderful with the nurse and the caregiver or the patient. Yesterday, seeing one of the patients in one of the assisted living facilities with a husband and wife, the wife being the patient, the husband said, "I want you to guarantee me, Dr. Cisneros, that you don't, that I love your nurse, Deborah, and I want to make sure I keep Deborah to the very end. I just think that she's wonderful, and your nurse's aide that comes and bathes my wife is wonderful." And it makes such a difference, that relationship, that you can't really quantify. It's one of those things that you can't put on a chart, but when you help people emotionally this way, it reduces their pain level, and it reduces their breathing trouble, or it reduces their symptom, whatever the symptom may be. Because studies do show when people are alone, when they're anxious and they're fearful, if they don't have an answer and they don't have a person, you have that human element lost, it really multiplies the pain. And the pain can be very emotional. So the total pain concept is something that's really huge. We don't want to just say that a person that has a pain level of a 10 gets morphine if we discover that pain is really emotional or spiritual pain. But if they describe the pain with an adjective that's really on par with physical pain, they say the pain is really sharp, throbbing, achy, burning, pressing. That's an adjective of really physical pain.